I'm Patricia Furey. I'm the Chief of Vascular Surgery at Catholic Medical Center. And I just wanted to present some of the cases that we've done at our institution. We've done about 30 cases or so. We have about 5 vascular surgeons and 3 cardiac surgeons, and we've all used this device. And we use it on a clinical basis and on a case-by-case basis. So I'm just going to go over some of the cases that we've done. The device can be used as a standalone device. It can be used for patients with claudication. It can be used in conjunction with a drug-eluting balloon for access, as Dr. McKenzie and Dr. Clare have indicated. Here are some of the case examples. This is a popliteal artery lesion, one of my patients who had severe diabetic disease as well as renal insufficiency, and he underwent angioplasty using a 6x5x60 shockwave device. And on the very end of the slide here, you see the post shockwave with a significant improvement in the appearance of the lesion. Here's another shockwave with a 7x60 in the infrapopliteal segment. On the right side, you see a picture of this. This is the same patient. We post-dilated with a 6x150 Lutonix balloon. And you can see a significant improvement in the appearance of the calcification behind the knee. This patient post-procedure had a significant improvement in the amount of rest pain that he had. He'd come previously with rest pain before and had had previous angioplasty approximately 6 months prior, which had not resolved with angioplasty. Here's another patient who had had a previous angioplasty. He was a diabetic patient and had previous SFA angioplasty and developed a recurrent stenosis in the superficial femoral artery and underwent a lithoplasty procedure. He has a mild dissection in this area, but post-procedure on ultrasound, it did not reveal any evidence of post-residual stenosis, and he was not symptomatic from this. We treated this with a drug-eluting balloon after the fact. Here's a patient, another diabetic patient with borderline renal insufficiency and rest pain who had a high-grade lesion in the anterior tibial artery. He had a vein graft, and on his ultrasound prior to coming in, it appeared as though he had diminished velocities and the vein bypass, but on angiography, it looked like he had a popliteal lesion with this lesion in the anterior tibial artery, which we used the shockwave device for, the small size. And then after, he had a significant improvement in the appearance of calcium in the anterior tibial artery as well as in the popliteal artery. And then we used a drug-eluting balloon in the popliteal artery. And here's another lesion that is just above a stent. On ultrasound, it appeared that this patient had an in-stent stenosis, but in fact, this stenosis appears just before the stent, and so we decided to use the shockwave device on the lesion itself, and was very successful in treating that lesion. And then we used a drug-eluting balloon. Here's another patient. This is actually, I don't think this is my patient. I think it's one of my partner's patients, had a vein graft and then a popliteal lesion with a lot of calcium in the midsection of the lesion with a 5x60 shockwave balloon. And you can still see some residual calcium, but a significant improvement in the appearance of that after using the balloon and a drug-eluting balloon after the fact. And this is the improvement of that lesion, and then the runoff, which is significantly better. Here's another anterior tibial artery patient with significant calcium in the proximal portion of the anterior tibial artery with a 4 shockwave balloon. And here's another patient with another popliteal and anterior tibial artery lesion and post-IVL with a 3.5 millimeter. and that looks significantly better. This is a patient that needed iliofemoral access for placement of a thoracic stent graft. And you can see the significant calcium in the iliac lesion there. And the stent was deployed. The shockwave device was deployed in the iliac artery. And you can see on the left-hand side there's a significant improvement in the appearance of that. And we were able to deploy the device through the left after the shockwave without any stent in that area. And this is a patient who had severe bilateral claudication, who also had significant superficial femoral artery disease, as well as popliteal disease, was an ongoing smoker. And we decided to use this device as opposed to stenting her due to her young age. And it's not a perfect post-procedure appearance, but she had a significant improvement without any stenting or any other treatment afterward. And this is post-shockwave using 7x40, and we used drug-eluting balloons after the fact. Another similar patient who just had the shockwave device used, but no drug-eluting balloon in the bilateral common iliac arteries with significant improvement. So in summary, this device has a lot of variability in its use. It can be used in the common femoral artery, although that's not something that we use frequently, but it can be used in patients who have had previous common femoral endarterectomy that you might not ordinarily use the device in that location, or possibly even the profunda. It can be used in the iliac system. It can be used in the tibials, in the proximal tibial artery, and in the popliteal artery in areas where you might not be inclined to use the stent. We've used it in some off-label indications. We've used it in the mesenteric circulation in previously stented areas. And so I think it has some very unique applications in the clinical setting where you might not ordinarily want to place a stent. And so we've used it in these circumstances where we have not been inclined to want to use atherectomy. It's been a go-to device in many instances where an atherectomy isn't appropriate for highly calcified lesions, so I found it very useful.